So thank you so much for that kind introduction. You'll forgive me just for starting my timer, and all will become clear in about 29 minutes' time. So exercise and psoriasis, what does the evidence tell us? And before I tell you anything, here is my disclosure. So it is a great pleasure to be the opening talk at this year's Psoriasis Association Annual Conference, to welcome you all to Manchester, and to share with you what my group have been working on in relation to physical behaviour and psoriasis over the last several years. You, the Psoriasis Association, have funded much of the work I will share with you today, and many of you in this room have participated in our research and co-designed our previous and future work in this field. And for that opportunity, on behalf of the team, I am enormously grateful. So to that end, I will, during the course of my talk, set the scene, explain what we did and what we found, what we think that all means, and share with you what we hope will come next. And if I can run precisely to time, we may have opportunity for a little bit of team spirit towards the end of the talk. So psoriasis needs no introduction to this audience. You will recognise this as psoriasis, and you may also be aware that psoriasis can range in severity from 1 or 2 plaques to near total skin surface involvement. And for some, having psoriasis can have a significant impact on quality of life. However, over the last decade or so, there has been a shift in understanding of psoriasis as simply being a disease limited to the skin, to psoriasis being a systemic, multi-system condition, predisposing sufferers to other related health conditions, such as inflammatory arthritis, cardiovascular disease, and metabolic syndrome. And the key word here is predisposing, and what that means is still hotly debated. And to summarise a complex debate, the 2 schools of thought on this are whether psoriasis itself is responsible, or whether lifestyle factors are driving an increased risk of other health conditions in some patients. But as clinicians, we are aware that accessing appropriate healthcare that addresses the complex, interlinked physical, psychological, and social needs of our patients can be really challenging. And this is in spite of the World Health Organization declaring an urgent need to address the consequences of psoriasis and to stop the exclusion of patients from healthcare settings and daily life. So it was against this background that 2 very important things happened virtually simultaneously. The first was this: the Psoriasis Priority Setting Partnership, or PSP, which was a highly collaborative piece of work championed by the Psoriasis Association and facilitated by the James Lind Alliance, which set out to determine the really important questions about psoriasis that those with lived experience of psoriasis and their healthcare professionals needed answering. Many people in this room today, including me, were involved in that process, which ultimately determined the top 10 list of research priorities in psoriasis. Here is the complete list of the top 10 research priorities in psoriasis, of which the number 1 research priority was this: do lifestyle factors such as exercise play a part in treating psoriasis? The second thing was an important piece of work undertaken by Lisa Alker, a PhD student in my group, whose PhD was funded, supported and promoted by the Psoriasis Association. And Lisa's work identified that patients with psoriasis are less physically active compared to age-matched people who do not have psoriasis, and that this is because of psoriasis-specific barriers, such as treatments, clothing choices, and extent, severity, visibility, and symptoms of psoriasis. And this led us to conclude that having psoriasis can prevent people from participating in exercise and from benefiting from health-promoting levels of physical activity. And it occurred to us that maybe this, in some way, contributed to the increased risk of cardiovascular disease and metabolic syndrome we see in some patients with psoriasis. But what are the health benefits of exercise? Well, of course, we are bombarded by the health-promoting aspects of exercise from a variety of sources, such as general advertising, social media, and even academic institutions. And indeed, the UK Chief Medical Officer, whose guidelines are highlighted on the staircase at the Institute of Sport here in Manchester, and they certainly encourage me to make a positive lifestyle choice when meeting with colleagues there. You read as you ascend the stairs, so you gain information the more you do. But I've transcribed it onto the right-hand side of the slide for you. So every step counts, especially when it comes to healthy aging. We discovered that you could lose 30% of your leg muscle by the time you were 70 to 80 years old. We've also proved an active lifestyle can combat this. Our work here in Manchester has informed the UK Chief Medical Officer guidelines. This means our work is used every time a GP offers advice about physical activity. Our research is shaping lives every day. Every step counts. So it occurred to me that if exercise could really impact all of these things on the slide here, then exercise itself must be anti-inflammatory, because all of these things are driven by inflammation. And if exercise is anti-inflammatory, which biochemically at least it is, then surely exercise might help psoriasis or help prevent some of the other health conditions linked with psoriasis. And so I formulated this hypothesis that physical activity constitutes a promising therapeutic intervention in the management of psoriasis, which may also offer additional health benefits for patients with psoriasis. And I set about designing a bespoke exercise program for people with psoriasis, drawing on the expertise of sport and exercise scientists, along with, most importantly, people with psoriasis. And there are several survivors of this particular boot camp in the audience this morning. And we were grateful for our working group in providing us with an aspirational design brief, advocating that our exercise program should involve coach-led group activities that were free, fun, and achievable, whilst also providing social support and having measurable health benefits. Neither vigorous intensity activity or swimming were considered acceptable, I agree, and it was suggested that walking was actually the most inclusive exercise modality, and given its acceptability to those both exercise naive and exercise experienced. And the working group specifically recommended that participants joining our programme should be able to incrementally progress from even a sedentary baseline to cardiovascular health promoting levels of exercise over the course of the programme. So, our final exercise intervention looked like this. It was a 10-week programme comprising twice weekly walks through beautiful green spaces here in Greater Manchester for small groups, no more than 5 people with psoriasis per group. And each walk was led by a sport and exercise scientist, Rory Shepherd. And having built our physical activity intervention, we recruited people with psoriasis to participate in a proof of concept study designed to measure the clinical impact of our physical activity intervention. And the study was set up so that participants would have a baseline assessment on enrolment, follow our exercise intervention for the first 10 weeks of the study, and then undertake independent activities for the final 10 weeks of the study. Now, one of the most important aspects of our study was that we dosed the volume of exercise delivered in each walk, just as I might dose a medication. And in order to do that, we drew on best practice in exercise program design by mapping the terrain of each route, the gradient of the ground covered, and calculated the walking speed required to enable our participants to progress from very low levels of activity to heart-healthy levels of exercise during the program. So the chart here on the left shows each week of the program, weeks 1 to 10, and you can see in this column here the energy expenditure per walk. So this increases walk on walk until participants hit the purple zone, and when they hit the purple zone, they are then exercising at the level of exercise recommended by the UK Chief Medical Officer. So having built our programme and recruited our participants, we were able to ensure the dose of exercise designed into each walk was delivered because each of our walks was led by our sport and exercise scientist, a kind of pacemaker, if you will. And in order to measure the clinical impact of our intervention, each participant had a clinical evaluation involving skin, cardiovascular, well-being and fitness assessments at baseline, after completing all 10 weeks of the exercise intervention and at the very end of the study. And this is what we found. Our participants had significantly improved psoriasis control, including reduced PASI, which measures the extent and severity of psoriasis, and Dermatology Life Quality Index, which measures the impact on quality of life. And 50% of our participants achieved what we call a PASI 50, which means that their psoriasis extent and severity halved over the course of the study. So to give some context to this, PASI 50 improvement is considered a clinically significant response. And benchmarking this further, treatment with methotrexate, for example, which is considered an effective systemic therapy for psoriasis, can achieve a PASI 50 response in about 63% of patients. And therefore, our PASI 50 response of 50% of patients was cause for great celebration within the team. And I actually remember the day in psoriasis clinic when Rory ran down the length of the corridor into the main clinic hub, waving his data in his hand. It's just a shame there weren't more people there. We also documented significantly reduced cardiovascular disease risk factors, including reduced systolic and diastolic blood pressures. And we also demonstrated significantly enhanced well-being, and that participants had increased functional capacity, which means that our participants developed significantly greater levels of aerobic fitness, endurance, balance, flexibility, and muscle strength and conditioning throughout the study. So taken together, these data suggested to us that physical activity may be very helpful in the management of psoriasis and may even offer a useful therapy for psoriasis. So we were very excited. But despite our participants being more active, and you can see here that the total volume of physical activity undertaken by our participants was now 4 times greater than the minimum physical activity recommended by the UK Chief Medical Officer, we observed absolutely no change whatsoever in total sedentary time. And total sedentary time is a measure of the total time over the course of the day spent sitting or lying down. And what this meant was that we had only done half a job, because inactivity, being sedentary, so inactivity constitutes the twin harms of limited physical activity and high levels of sedentary behaviour. And sedentary behaviour itself has a detrimental effect on health and well-being, irrespective of the amount of physical activity undertaken. So we went to the literature and had a good think about this. Our patients and our participants were more physically active, but they were not less sedentary. How could we get around that? And actually, a neat way to get around that is to break up sitting and sedentary time with short bouts of physical activity or exercise. And this is sometimes called exercise snacking. And so we have been working with both the Psoriasis Association and with colleagues in the room to develop a new improved physical behaviour intervention called Move Smart, which will reduce and interrupt periods of sedentary behaviour whilst increasing tolerable physical activity. And we hope to trial Move Smart later this year, and I hope that many of you will be interested in taking part. Now, the way Move Smart works is for people to receive a tiny prompt if they have been sitting or not moving for 30 minutes. And that includes all of you in the room, because I've been timing you. So if you've not been sitting for 30 minutes, if you've been sitting and not moving for 30 minutes or more on receiving the prompt, you undertake a movement of your choice from a menu of choices. And if you use a stick or a trolley, you can use that. The key thing is to move for 2 minutes on receiving the prompt. So here is the prompt. To help me deliver the prompt, I'd like to invite Anna, who's a medical student from the University of Liverpool, up onto the stage. Come on up, Anna. I'd like to invite all of you who'd like to participate to stand. Now you've got 2 choices. If today's a good day, if you've got lots of room, you can if you're exercise experienced, please follow Anna. If you're a more regular, ordinary sort of person, follow me. And all you have to do is move. Side to side shuffles, or Anna can do something a bit more exciting. Zenas, I hope you can see that I am warming up the room nicely for you. And you will have lots of fabulous talks today, but perhaps this talk is one of the only ones that will have you healthier at the end. than you were at the beginning. That's lovely. Thank you, everybody, for taking part, and thank you, Anna. So we've tried our prompting system in our pilot work, and it's been very, very well received by people who have tested it for us. And I thought I'd share a few verbatim quotes on the feedback that we've received. My favourite is the bottom one. I still watch lots of TV, but I am now standing during the adverts. It is that easy. So, in summary, our work has identified that people with psoriasis, because of their disease, are less likely to engage in physical activities, but that increasing physical activity could constitute a promising therapy for psoriasis. In addition to our proof of concept work, it suggests that increasing and adding physical activity strategies to standard therapy for psoriasis could improve the additional health burdens of depression, cardiovascular disease, and metabolic syndrome. However, we also recognise the crucial importance of trying to reduce total daily sedentary time, which, as I've explained, has a detrimental effect on health, independent of the amount of physical activity undertaken. And we hope to begin a clinical trial of a new intervention called Move Smart later in the year. So finally, as I close, I would like to acknowledge our funders, the students and scientists who have undertaken the work, our research participants, our fabulous lived experience advisors who have worked with us every step of the way. Thank you very much for listening and for participating, and I am very happy to answer any questions you may have.
Helen?
Yes.
Can I, thank you. I don't know, have we got one? Yeah. Right. Thank you. I just wanted to thank you. Do I need to press it, or is it? No. Okay. So I'm Julia Schofield. I'm a dermatologist, and I'm currently the vice chair of trustees. Helen, I just want to thank you for such a brilliant opening presentation, not least because you have highlighted the importance of the association in funding research and demonstrating very clear outcomes. So I've listed what we've helped fund. The priority setting partnership, which put exercise at the top 10, and then actually Rory Shepherd, Helen's just sent me a piece of paper, was funded by us, as was Lisa Alka, I think.
Correct,
so,
yes.
you know, this is just amazing to hear you speak, and thank you very much indeed for coming to talk to us today.
Thank you,
I did just want to ask a question.
Yes.
Presumably their treatments stayed the same throughout. Their creams, ointments, systemic therapies were all the same throughout.
And for 3 months before enrolment, absolutely stable disease and stable treatment. So any treatments, but they all stayed the same.
Thank you. Any other questions?
Hi, Philip Lane, Worcestershire. Many local authorities do have health walks. Your project is related specifically to skin conditions. Are you aware of any other areas in the UK where local authorities have got similar programmes?
So I think, to the best of my knowledge, we're the only centre that's developing this specifically for psoriasis, but you're quite right. There are many local authority areas that offer social prescribing or offer sort of health walks. In fact, we here in Manchester partnered with the Salford community team who were offering a very similar walk system for just the general population, but we have very much kind of adapted that and had it very sort of specially focused on patients with psoriasis, and we've found that to be really rewarding, and that's allowed us during this sort of study construct to then tease out specifically how it helps or how it may help patients with psoriasis, and what volume of exercise do we need to recommend for patients, given that we're dealing with quite a high inflammatory drive on a particular disease process. So I think it's going to help us specifically recommend and offer a safe space for psoriasis patients.
It was really just a question about obviously the benefits of exercise and reducing stress levels, and then whether it's the reduction in stress levels that was to reduce the improve the psoriasis, or whether it's actually the exercise itself. Is there any way of separating the two?
Yeah, so we can't sort of tease that apart with the work we've done, and we're hoping to look at that much more closely in a follow-on study. What we did notice, though, was that our effect on stress levels, well-being, was less than we might have expected and what other groups have found in other related health conditions. So we're not sure whether that means psoriasis is doing something differently, or whether indeed it was even a hangover effect from the pandemic when the population was perhaps just less happy, greater levels of stress. So it's difficult to tease that all apart, but we plan to try and do so in future work. That's lovely. Yes.
Can I just ask one more question
Yes.
on that? Because I think that's a very astute observation. If you had just put 5 people with psoriasis together twice a week, having a nice chat and a cup of tea,
Yes.
do you think that would have helped?
Yes, we do. And in fact, we got a lot of really useful feedback from the ethics committee on exactly that. You know, how are we going to tease out that effect from the anti-inflammatory effect? So we can't easily do that. We need to move to a clinical trial model, which is why we want to try and look at Move Smart as a way of doing that. There must be a benefit. And what's the sweet spot? We did keep the group sizes exactly the same to try and take group sizes and small groups, large groups out as a confounder. But you're quite right. We have to kind of caveat it with, it could be really nice to be in a small group of people who you get to know over 20 walks, 10 weeks.
Thank you very much, Helen. Oh, we've got one more question there.
I just suddenly thought, were the walks during the summertime, and could it have been...
So my
light experience?
picture, if I could quickly go back to it. Can I just quickly go back to it?
I just wondered whether it was exposure to sunlight.
Yeah, that's a super good question. So I have a picture in my slide deck. So Rory insists, when talking about the exercise intervention, I share these slides. He took them from the walks. These are action shots. He's actually a very good photographer. So the snowy picture is so that everyone in the room knows that this happened throughout the season. So yes, there could be some UV effect, but he was out in the glorious liquid sunshine we have here in Manchester, sunny days and snowy days too.
You don't get any sun here. I was a medical student here for 5 years.
Helen, thank you
You're very
much.
welcome.
We will need to move on, but thank you for really...